Well, good morning, good afternoon, good evening, everyone. We're going to have a really fun conversation with Dr. Zeke Emanuel, who is a fount of wisdom and ideas and sometimes controversy. We're going to give it just a few more minutes seconds, I should say, for others to join. And then we're going to dig right in. So let's start. Just to give a little bit of background, Dr. Zeke Emanuel is very well known, widely respected. He is trained as an oncologist. He's a bioethicist and author of many books, a health policy expert. He is senior fellow at the Center for American Progress and chair of the Department of Medical Ethics and Health Policy at the University of Pennsylvania. He contributes frequently to the New York Times and other leading journals. And his latest book has one of the best titles of any book in recent years, Eat Your Ice Cream. And let's start with that. One of the challenges we have in public health and healthcare generally is that the exciting breakthrough health tip that is clickbait worthy probably isn't going to make much difference in your life, but very simple rules that have been known, as you say, for thousands of years may in fact make a huge difference in your life. How do we break through the noise to get the valid information through to people, Zeke?
Well, I think you're 100% right, Tom. Most of what leads to a healthy, long, happy life is not news. And part of the problem is our environment, information environment really does require clickbait that sounds sexy, which is why you get all this interest in peptides and other supplements that are kind of nonsense and don't do anything and may be harmful. And I do think we need to emphasize just a few things that people need to do and to help people do them. One of the big problems is, despite knowing what to do, people have a hard time getting started. And changing habits, as we all know, is one of the big challenges in life. And so part of the reason for writing the book is, here's what to do, but here's also how to get started doing it, and not trying to get people to do dramatic changes across all the things they need to do, exercise and eating and sleeping and socializing, and but focus on a few pivotal changes. And I do think pointing out when the influencers are wrong, but also potentially really dangerous.
So if there's one not dangerous, but helpful life hack you would have for people to live a long, healthy, happy life, what would it be in addition to eating ice cream?
Tomorrow night, have a dinner party with friends. It gets you social interaction, good stimulating conversation to keep your mind sharp, and good food that is healthy because you can cook it or order it. And, you know, getting 3 wellness activities and behaviors in one evening is what I call a wellness trifecta.
Great advice. Let's talk about healthcare and the healthcare system. What have you learned from studying healthcare systems around the world? What's the best way to get it done? And how do we get out of this terrible dynamic where the healthcare system pays for care, not health?
How long do you have, Tom?
I know you can explain anything in 30 seconds, so go right ahead.
So the first thing is, you're 100% right. Our system is a disaster. One of the ways I like to illustrate how bad it is there are 5 goals of every well-functioning healthcare system. First, you need universal coverage. Everyone should get the benefits. Second, you need to have reasonable and sustainable costs. Third, you need to have high and constantly improving quality. You need to have narrowing disparities. There's disparities in every healthcare system, no matter how egalitarian the country, and we need to be narrowing them. And the last is the doctors, the patients, the other clinicians, the public need to be satisfied with it. What's interesting is many healthcare systems around the world satisfy 2, 3, and even 4 of those.
We are 0 for 5, batting zero.
That's my point. We are 0 for 5. We get none of those. Now, some people The person I like to call the American booster says, oh, we are the best. If you got sick, you don't want to be treated anywhere but the United States. There are some things we're the best in, mainly cancer, and I am an oncologist, so I'm biased to that. We do very well in cancer, and I think I have a hypothesis why, but we're pretty bad at almost everything else. We're bad at controlling hypertension. We're bad at actually treating diabetes. We're bad at
we used to be pretty good at vaccinating kids.
Pretty good, but not the best. Our infant mortality sucks, but also, people talk about cardiology. We're actually very, very good at 30-day survival after a heart attack, but we're terrible at 1 year survival after a heart attack. Canada, Britain are better than us. And I think part of the reason is we're really bad at chronic illness, and what afflicts people today is chronic illness, which requires constant attention and also seamless ability to pass. If a patient gets to the hospital, go back to the primary care doctor, or to go back to a specialist. We don't do that very well, which is one reason my hypothesis is that cancer is good, because the oncologist takes responsibility and sees the patient once or twice a month for the duration of treatment. Survivorship, that's a little more iffy, frankly. But I do think the constant touch points, how we build that into a system, especially with patients with chronic illness, we're bad at. Fixing the system is a whole different ballgame. One of the problems is, as you point out, we pay for care. We don't pay to keep people healthy. We don't pay primary care doctors. We pay to fix things, and that's a disaster. And we also don't have a budget. Every other country, high-income country in the world, but Switzerland has a budget. And we are the 2 highest spending countries per capita in the world when we don't have a budget. And part of what we need, especially if you want to get reasonable and sustainable costs, is a budget.
So let's talk about primary care. For 50 years after the Alma Ata conference, the world has called for primary care to be improved. And for 50 years, we've pretty much failed. You can count on really the fingers of one hand the countries that have good primary care systems, and many of those don't do a good job with the chronic diseases. We at Resolve to Save Lives, we have a big focus on high blood pressure for the very simple reason because you can save the most lives by controlling high blood pressure. We are Resolved to Save Lives, after all. And South Korea is at 60% community-wide control. Canada is at 50%. US is not terrible at 45 to 50, but that means basically we are getting the most important question in healthcare wrong half the time and spending $4.5 trillion to get that. For a tiny fraction of that, we could do a whole lot better, but we don't, because we have weak primary care systems that don't incentivize health. How could the US or any country change the way those incentives are structured?
So I think it's a double-barreled question, or at least the answer is double-barreled. The first is, I agree with you. We need to emphasize primary care more. One of the things I've learned in the research for my last book is the moment we got sort of the specialist primary care seesaw out of whack to heavily specialist turned out to be World War II, as best as I can tell, because the US government wanted to make sure that soldiers fighting in the war got the best care available if they got wounded and after the war. And that was viewed at the time in the 1940s as specialist care. And Eli Ginsberg, which will be a name for a very few number of people who listen, the original health economist, was entrusted to set up the system of care. And one of the things he did is to try to get specialists to come into the military, was to give them a higher rank and to pay them more than primary care doctors. And that continued after the war because, of course, they were paid more. They expected to be paid more, and the insurance companies continued that process. Clearly, many doctors are not motivated by money, but once you have a gap where primary care doctors are earning $250,000 and a surgeon is earning $1 million a year, at some point that just becomes impossible to do, and people stop doing primary care and start doing specialist or surgical specialties. So we clearly need to, among other things, to raise both the prestige and the money in primary care. I don't think it's that hard. Right now, the U.S. spends about 4 to 5% of healthcare dollars on primary care. You bump that up to 8 or 9%, and suddenly docs are making, primary care docs are making what oncologists make, and you change the whole incentive structure. You also have to decrease the number of patients that they're responsible for. The idea that they're, a panel is 2,000, 2,500 is crazy. It needs to be somewhere closer to 1,500. And the last thing I would say is you need to pay for outcomes, not for procedures. So one of the things you have to do is pay doctors to control blood pressure. So big bonuses for a small number of high value activities. Controlling blood pressure is one of them. I think you're 100% right. The most important thing our system can do is to get people who have high blood pressure under control. And we know you can achieve that. The CDC recognizes, blood pressure champions. That's groups that have been able to control the blood pressure of 80% of their population or more. We know what's involved. Everyone does it more or less in the same way. And I think that's going to be important. Let me parenthetically say, I think AI is going to be really good in that process of controlling blood pressure.
Let's get to AI in a minute, but I want to stick with primary care and the financial incentives for a minute, because if it were easy, it would have been done. And
no,
it's not easy, and it hasn't been done. And part of the issue is the political economy. Hospitals and specialists are capital intensive. They are important for a lot of things. There is great care available for complicated conditions. And there's not really much of either a constituency or a business case for primary care. It's just the right thing to do to keep people healthy.
I think there is a business case. The problem is that you have entrenched interests, and no one has actually flipped it so that you could actually get a primary care doc to earn $500,000 or $600,000 a year. And I don't think that's an impossible design element. Lots of places have achieved that. I do think it is going to be the fact that we're going to have to take some money away from hospitals and take some money away from the specialists and focus it on primary care. And the idea that there's no business case, if you prevent hospitalizations for hypertension or diabetes, there is a business case for primary care. If you keep people healthier, there is a business case.
Well, Zeke, it's obviously the right thing to do to spend proportionally more on primary care, but how do we get from here to there? Because there's a political buzzsaw that prevents that, or we would have done it already.
No, yes, there is the entrenched interest of the specialist groups. No doubt about it. Are we going to have to take them on? Yes, to some degree. And I think that's going to be absolutely necessary. Everyone's got to give up something. But if primary care is 4 to 5% of spend, hospitals are 31, 32%, bringing them down 1 or 2%, bringing specialists down 1 or 2%, I think is eminently possible. Hospitals right now could become a lot more efficient. We know that they spend between 17 and 20% on administration. If we got a better billing system that was simpler, didn't have such overhead, if we got a better credentialing system that didn't have so much overhead, you'd have a lot of savings and reduced administrative costs in those areas. So I'm not nearly as pessimistic as you are. You do need to have political muscle, and I do think the American public is ready to have a change on that. And all the polling shows they think the system's in crisis or needs major reform. What we don't have is a plan, and we need to have a. You can't reform something with nothing.
What about the ACO idea, doctor-managed ACOs, accountable care organizations, where when primary care prevents hospitalizations, they make more money. This is a promising model because Goodhart's law, when an indicator becomes a target, it ceases to be a good indicator, often does show there are lots of ways to cheat on indicators. But whether or not someone's been hospitalized and how much they've spent on healthcare, that's pretty objective.
Yeah, I agree. And I think, that's ACOs are a reasonable model. One of the things we're doing now is to try to make it easier for ACOs to be even more efficient. One of the problems in the ACO program through CMS is they don't give data back to the ACOs about how they're performing in a very usable way. And they have to spend a lot of money, millions of dollars, to get the data CMS gives them and convert it into usable information. We're trying to make that free to save that kind of money, get the middleman, the Milliman's and company out of the way so that they can actually get the data and be more efficient without spending millions of dollars on IT. That's the kind of thing you need to think through. And there really is a lot of money there that could be saved. Now, there are some middlemen, even good middlemen take a lot of money. And if the ACOs could do that themselves, there'd be a lot of pay for the docs.
So data takes us to AI. Let's start talking about AI. I have to say, AI has revolutionized my workflow more than anything in my work life. And I've said publicly many times that I think at this point, it's malpractice to care for a patient without AI, at least as part of the team. I know there's controversy about the issue of autonomous AI and where things are going. Let's first start generally with AI and then think about the AI role in primary care and also in global health. Over to you.
Well, let's be very clear. We are less than 4 years into the LLM era, introduced in November 2022. It's amazing how much different it is today than in 2022. The progress is incredible. All the tests since January 2024, and we've just published in JAMA on this, and we have a supplement to the publication that shows every single study published comparing humans to AI, human AI hybrids to AI, show that AI equals or exceeds humans and many human AI hybrids at soliciting information from patients, getting a differential diagnosis, selecting the guideline concordant treatment, selecting the right tests to narrow down the diagnoses and manage chronic conditions like diabetes. Now, a lot of those tests are not in the real world. They're with patient actors or they're with chats. Some are in the real world, and they do so that AI can work. What we need is to get a regulatory structure and a liability structure that allows more testing of AI in the real world and more deployment of AI in the real world. And I think that's going to happen because I think it addresses, at least in the United States, two big problems. Problem number one is access. Lots of people don't have access to doctors, especially primary care doctors. And this can solve that problem without taking a single patient away from a doctor. Second is geography. Lots of rural areas are underserved, not just in primary care, but in all sorts of specialty cares, physical therapy, occupational therapy, many pediatric areas. And AI can solve that problem too. And I think that's going to happen. And I think I've just, in this article in JAMA, we predicted by 2030, it'll be the first class care for many Americans. Now, will it do surgery? No. Will it catch a baby at delivery? No. But that, most of medicine is not that stuff. Most of medicine is about managing chronic illness. And that AI we know is better than people.
Is AI better than the average doctor, or is
it's also better than the experts in many cases? And whether it's better than the experts, the absolute best experts, irrelevant. The absolute best experts take can care for a very few number of patients. We have 340 million Americans. We need a lot of doctors, and it's certainly as good as the average doctor, board certified and all.
How about global health? In the work that we do around the world, we see huge waiting rooms full of people with a wide range of illnesses. And, in a lot of lower income countries, Occam's razor doesn't cut it, right? So Occam's razor, the least number of diagnoses to explain the most number of symptoms or findings. But often someone will come in, they've got malaria, they've got intestinal parasites, and they've got something else, a pneumonia or a cancer or something. I'm not saying that this is going to be a different kind of challenge, but it's a different kind of context. So one use case that's been discussed is have a bot do not the triage, but the provisioning. So by the time someone comes in, they've had a series of questions, they've had their vital signs done by either a person or something else, and you've at least told the clinician, hey, these are the main concerns, these are the findings, this is what you should validate. I understand that's the hybrid model that's not most favored by autonomous, but we're not quite there yet. And we've got most people in the world who don't have access to competent healthcare. Where do you think AI can do the most good?
I think it can do good at every stage you've mentioned, and including autonomous. So first of all, as you point out, access is a problem worldwide, and geography. A country like Ethiopia, you have over 100 million people, 95 million of which live in rural areas, and you have to get to them, and you're not going to get to them by having doctors every which way. At the moment, you have community healthcare workers, but AI is going to be better than community healthcare workers. Yes, there are complicated illnesses, and patients often are comorbid with multiple conditions. AI is fine for that, right? AI, like medical students, need to be trained. Doesn't take 4 years to train an AI. And they're going to learn how to recognize multiple comorbidities. Part of the problem, I think, in the world evaluating AI is a lot of people take, ChatGPT or Claude or Google Gemini right out of the box. You wouldn't take someone who just graduated college and then test them against a human physician. You do need to train them, and you need to see the areas that they're better in. And I think the more training and the more reasoning models, the frontier reasoning models we have, that AI is trained on global health problems, the better it's going to be. And so I think this is a learning curve. The thing about AI, I think, that we don't fully appreciate is it learns a hell of a lot faster than humans. And so it can handle multiple comorbidities at once. Today, no. But as we train it, and over the next year or two, yes. And I think actually the world ought to be investing heavily in AI for global health conditions. So I'm actually quite bullish that AI will make a much bigger difference globally than it will in any particular high-income country. But we also, the other thing I would say, Tom, is, people talk about distrust of people are using AI a lot for diagnoses, and doctors are using AI a lot for diagnoses. So whatever the problems are, there seems to be growing confidence in AI by both the public and the medical profession.
What about the inconstancy of AI? You can ask the same question twice and get two different answers because of the nature of LLMs.
Well, I think it also is the case of how you phrase it, how you put it, what specifically you're doing. Two things are going to happen. We're going to be better at feeding bots the right question, and LLMs are going to be better at interpreting what we actually want behind our Claudish or Clodish question asking. And I think we're going to come to some happy medium where the AI actually understands better what we want and what we're asking about.
Let's change gears and talk about vaccines and health policy in the US as we close out the last few minutes of this conversation. What's your take on what is driving these changes to vaccine schedules and vaccine policy What's behind it, and how dangerous is it from your standpoint?
Well, let's begin with the danger. It's very dangerous. And the second point is what's behind it is Donald Trump. Donald Trump has been skeptical of vaccines and thinks vaccines cause autism for many years. I know it's at least a decade. I met him in December of 2016, and right at our very first meeting, he asked me whether I thought vaccines cause autism. I explained why. I explained why the Lancet paper with Andrew Wakeman was wrong. He wasn't having it. And it isn't a data thing. It's not like, he's responding to data. That's his suspicion. And I think everything RFK Jr. has done has Trump's blessing on it. And RFK obviously does it. And, he also, he has a financial interest as well as a belief about it. They're just not supported by the data. On the other hand, 70% of the population believes in vaccines, wants their kids to get vaccinated, et cetera. But you have a small percentage who are against it. And you have a 20, 30% of people who are uncertain and don't have enough time to sort through the various arguments. And they're like, why should I take a risk? Especially when the government is blessing me to not take a vaccine. So I'm just not going to do it with my kids. That's where we're at. And I think until we can have more trust in government, which is hard given social media, and more trust in experts, and have people understand the science, we're going to be in a bad situation no matter who gets in, because changing these attitudes is not something you do overnight.
How about the healthcare system more broadly? We've just got the news that 4.5 million people will lose health insurance within the next year or two. And there is the risk, albeit unknown how high the risk is, that the exchanges will go into the so-called death spiral, where the healthy folks are not signing up and the costs become unsustainable. You have an optimistic view of we can make progress with expanding primary care, but what's happening right now is access is getting less and costs are rising.
Yeah, our system is on a path to make things worse. There's no doubt about it. The political scientist from University of Michigan, John Kingdon, argued that you can get major reform only when three things come together. First, the public recognizes there's a problem. We're there on healthcare. The affordability issue, the access issue, all of it, the public is on. Then you need a policy that has been argued about, vetted, and can answer, has a plausible chance of answering and solving the problem. Then you need a political open window. Where we're at now in healthcare is that we don't have a plausible policy to propose to people. And I think that's where the responsibility on the healthcare system, policymakers, and health policy experts is to come up with a plausible alternative. We haven't done that work. I think, most people, I'm going to be a doctor and diagnose the whole health policy community, but most people in the community are depressed. They see exactly what you said, which is the unraveling of the accomplishments of the Affordable Care Act, the unraveling of Medicaid, the threat to the exchanges because of costs. And they're like, throwing up their hands and, no, the answer to the problem is, I've got a solution. Here it is. And that's where we need to go.
In our last minute, I want two good pieces of advice from you. One, for individuals, what to do in addition to having a dinner party tomorrow night. One other piece of advice for individuals for their health, and for the body politic, a prescription for our health.
So I think the first one for individuals is to pick the one thing you think you need work on, or the two things commit yourself over the next 6 or 8 weeks to changing that. Maybe you need to exercise more. Maybe you need to socialize more. Maybe you need to sleep more, you can change your habits in 6 to 8 weeks. There's a lot of good data. And, if I were recommending to someone not knowing anything in particular about
Great.
them, I'd say,
okay, choose one habit and
social life. It's social life. Stick to it.
Choose one
The
habit and
healthcare-
fix it in 6 weeks. And
Yeah.
for our country and for the world, what?
I think people are hungering for a disruption of the healthcare system that really solves the problem, and they want a proposal that is going to make it more accessible for them and more affordable. I think that's not as hard as it looks, but it's not something you can do by just tinkering with the existing system. You really do have to have more comprehensive reform. You can't squeeze out the administrative costs. You can't realign incentives by tinkering. It does require a big move. Probably the single biggest move that would give relief to people is to get rid of deductibles. Look, deductibles, frankly, are simply a cost transfer from insurance companies to people. Why? Deductibles on chemotherapy. When I prescribe a chemotherapy for a patient with cancer, right, I want them to take it. I don't want them to have a financial barrier to taking it. Deductibles just create a financial barrier to doing the right thing. And by the way, the data from the economists show it actually doesn't save overall costs. So you want to get rid of deductibles. That's something we could do. That would be
very popular
feasible.
Policy, I'm sure, with everyone.
And it won't cost you more.
All right, Zeke, thank you so much. Thanks for your leadership, your energy, your commitment, and your great ideas for a longer, healthier life for individuals and our communities.
Thank you, Tom. It's been a pleasure.
All the best.